associated with it. Her second complaint was breathlessness, which was of 5 months duration. It was initially an exertion and later progressed. She progressed to being breathless at rest. She progressed from NYHA class 2 to 4. Orthopnea was present. There was no history of PND, no history of cough, wheeze, or fever. She also complained of a swelling of both her legs, which worsened over the last 1 month. It was gradual, progressive, and was associated with distension of the abdomen and facial puffiness. There was no history of chest pain. There was no cough, wheeze, or fever. No photosensitivity, oral ulcers, or tingling paresthesias. There's no history of dryness of eyes or mouth. No hematuria. No persistent cough. No altered bowel or bladder habits. No past history of tuberculosis. No other comorbidities. She was born to non-consanguineous parents. Past treatment history that was significant was there was two history of attempts of drainage of fluid from the heart and drained large volume serous fluid. She was started on ATT at an outside center. On examination, she was tachycardic with a heart rate of 148 per minute and had a collapsing pulse. Blood pressure was 100 by 60 millimeters of mercury. Because she had history of probable pericardial effusion, we looked for pulsus paradoxus, but it wasn't present. Respiratory rate was 34 per minute. She was afebrile. JVP could not be assessed because her right EJV was cannulated. On general examination, she had icterus. There was bilateral pitting pedal edema up to the mid shin. She had head bobbing sign. Demerset sign was positive, but there were no other peripheral signs of atrial aortic regurgitation. No cyanosis or clubbing. Cardiovascular system examination, apex was hyperdynamic, was palpable in the fifth and sixth intercostal spaces, 2 centimeters lateral to the midclavicular line, with a grade 3 parasternal heave and palpable second heart sound, dullness in the left second intercostal space. Cardiac dullness surpassed the apex. S1 was soft. A grade 4 pansystolic murmur involving the tricuspid region was heard in the lower left sternal border, radiating across the precordium. S2 was loud. Respiratory system examination, she had increased vocal fremitus in the left inter and infrascapular areas. Coarse crepitations were heard in bilateral infrascapular areas. Per abdominal examination, liver was palpable 2 centimeters below the left costal margin, was non-tender, and had a firm sharp border. Spleen was not palpable, shifting dullness was present. There were no gross or focal deficits on central nervous system examination. Summarizing the case, Ms. G, she presented with breathlessness and palpitations, and on examination was found to have bilateral pitting pedal edema, icterus, a down and out shifted hyperdynamic apex with heart borders and percussion surpassing the apex, a pansystolic grade 4 murmur in the tricuspid area, grade 3 parasternal heave with loud and palpable P2, all suggestive of a pulmonary hypertension with ascites and bilateral basal crepitations. She had been evaluated outside and had undergone pericardiocentesis twice. Does anyone want to attempt on the differentials? Go ahead. Uh, yeah, she has clinically she's presented biventricular failure with features of pulmonary hypertension and okay. The differential diagnosis that we considered here were she came in with pedal edema, icterus, ascites, crepitations, and features of pulmonary hypertension. The cardiac causes that we considered were right heart failure with cor pulmonale, left heart failure. She presented in congestive heart failure, valvular heart disease, which could have precipitated this, or a congenital structural acyanotic heart disease. Other causes was constrictive pericarditis, probably secondary to TB. Pulmonary causes, she didn't have history of uh, suggestive of COPD, but causes that can be considered as COPD, interstitial lung disease, chronic thromboembolic pulmonary hypertension. Hepatic causes are cirrhosis, which can be alcoholic, viral, metabolic causes, causing hepatopulmonary syndrome or portopulmonary syndrome. But Chiari syndrome is another differential. Other multi-system causes could be amyloid, SLE, rheumatoid arthritis, systemic sclerosis, and infective causes such as TB should also be considered. The differentials for a structural heart disease with a pulmonary hypertension that we considered were valvular heart disease, that is AR or MR, or a congenital acyanotic heart disease such as ASD, VSD, or a PDA. Recurrent for the recurrent pericardial effusion which she had outside and presented to us, we considered viral. The causes we considered were infectious, that is viral, bacterial, and fungal. That is Coxsackie, ecovirus, and HIV.
You need to have a unifying diagnosis, no, for everything.
Yes, ma'am. Yes, ma'am. Ma'am, we were initially thinking lines of TB with an underlying. She had a pericardial component and structural heart disease, ma'am. That could not, we couldn't unify that into one diagnosis. Ma'am, our first differential, which we considered initially, was a rheumatic heart disease because she had both valvular involvement and pericardial involvement. But acute rheumatic, ma'am, this it it will not be a chronic. It will not be a rheumatic. It would have. She would have. It should have been an acute presentation with rheumatic fever, ma'am. If it should have been with the peric. Yes, ma'am, that doesn't fit in. Ma'am, we evaluated for each of these separately. Um, ma'am, we were able to appreciate only a tricuspid regurgitation murmur, ma'am, of pulmonary hypertension. Yes, ma'am. Ma'am, PDA murmur will be a continuous murmur, ma'am, which was absent in this patient in the infraclavicular, left infraclavicular area. Uh, yes, ma'am. Um, sure. Ma'am, on evaluation, she was found. She had. We were. We evaluate her serum electrolytes were normal. Her troponin was slightly elevated at 33.9, which and for which on repeat values was 48. Urea creat were normal. LFT showed elevation of TBDB with slight elevation in her SGOTPT levels. She also had a mild INR elevation. Uh, yes, ma'am. Because she had breathlessness also, but there was no. Ma'am, whether one set could have been done only.
No, when do you do CKMB and troponin, trop T?
Ma'am, for acute coronary syndrome.
Yes, did she come with that?
No, no, ma'am. No,
That really help you. So these tests are to help you make your diagnosis, right? That those tests are.
her TSH was slightly elevated, but she had no clinical features of hypothyroidism. Two blood cultures and one bone marrow culture showed no growth.
So what? Why did you do?
Ma'am, she
Were you suspecting an infective endocarditis?
Ma'am, it could, yes, ma'am. We were suspecting.
Did she have fever
She did not fever, ma'am.
to suggest an IE? No, right?
No,
And why? What about a bone marrow? What was the indication to do a bone marrow for her?
ma'am, she was treated for 2 months for TB, ma'am. There is the um, possibility. She had multiple admissions outside. She was treated extensively. That is why the differential.
Yes.
Yes, sir. We did an ECG. Um, so her chest X-ray showed a massively dilated heart, cardiomegaly, with bilateral hilar and low bilateral basal infiltrates. Ma'am. Her ascitic tap was suggestive of a high SAG low protein um ascites, which was probably secondary to cardiac cirrhosis. Uh, the pericardial fluid that was aspirated and evaluated also showed a transudative picture, but it was blood stain. There was no evidence of uh, infection or tubercular involvement. PET CT was done to find if there was any in um, malignancies that were present that could have caused the effusion, but it only showed an area of active uptake around the right atrial pericardium with no other, which could have been infective or inflammatory with no other active uptake elsewhere. Her ECG done showed right axis deviation with tall and wide P waves, which was suggestive of biatrial enlargement, and with a on this ECG with a 4:1 conduction block. However, when in the void, she had a variable conduction block from 2:1 to 4:1. Holter study that was done showed she had tall and wide P waves. Ma'am, this is just sawtooth pattern, ma'am. Uh, Sorry, sir. Sir, her lead 2, lead 3, there is, yes, sir. I'm sorry, sir. No, sir. No, sir. Yes, sir. No, sir. I have written that, sir. This, on the right side, I have written it. Holter study was also suggestive of an atrial flutter with variable conduction block. Echo done showed a large ASD with of size 46 millimeters with pulmonary hypertension with paradoxical septal motion and mild pericardial effusion, which was loculated and present below the right atrium. Her cardiac MRI also showed was done to rule out constrictive pericarditis, showed a large ostium secundum ASD with no features of constrictive pericarditis on the cardiac MRI. Ma'am, we were not able to appreciate the split, ma'am. She was very tachycardic, not able to. Yes, sir. Um, so there is features of pulmonary hypertension with congenital heart disease. Yes, sir. Yes, sir. Yes, sir. Her second problem was the pericardial effusion, sir. Yes, sir. Yes, sir. It has been tapped twice outside. Sir, we were evaluating for that. So she didn't have any feature. So because she had a congenital heart disease, it could be secondary to an infective pathology. Uh, so TB would be one differential, sir. Second, sir, so not with respect to the congenital heart disease, she could have an infective endocarditis, sir, but that won't explain the pericardial effusion. Yes, sir. Yes, sir. Only, only in the pericardium, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Um, for further evaluation of the pericardial effusion, we did the inflammatory workup. ANA, SSA, SSB were negatives, complements were normal, dsDNA was normal, ANCAs were normal. She had an elevated RF of 162 and anti-CCP was also elevated at 119. APLA workup was negative. The final diagnosis that we considered were a probable rheumatic pericardial effusion, which was an extra-articular manifestation of rheumatoid arthritis. She had also developed TBDB elevation with mild SGOTPT elevation, which resolved on stopping her ATT. So we considered rifampicin-induced cholestatic jaundice as the cause for the same. She had a large ostium secundum ASD with pulmonary hypertension. Uh, Clinically was still in having a left to right shunt and also had a atrial flutter with variable conduction block. I'll be discussing mainly about the non-articular manifestations of rheumatoid arthritis. This patient presented without any involvement of joint pains, and extra-articular involvement in rheumatoid arthritis is common. It's severe and usually presents years after involvement of the joints. Exception is lung involvement, and it's the pathophysiology is driven by the same set of cytokines that drive the joint disease. The hematological manifestations, the most common symptom is constitutional, which is fatigue. Other symptoms are hematological, which is the patients can present with microcytic hypochromic anemia. Sure. Uh, Going through during the, it's important, last slide. Sure. The learning points are that clinicians may consider the possibility of extra-articular involvement in rheumatoid arthritis in the absence of a typical joint involvement, and checking a specific serology when malignancy and infections have been ruled out will help with diagnosis and appropriate therapy selection. In patients who present with pericardial effusion, RA should also be ruled out. Presence of autoantibodies can precede clinical disease by years and can prevent joint destruction and can suppress disease progression if identified and treated early. Yes, ma'am. We gave her a therapeutic trial of ATT for 2 months, and then
you're not sure of your diagnosis, right? After all this, why did you give her ATT?
Ma'am, we didn't want to start her directly on colchicine and NSAIDs, ma'am, which was first line because she was getting anticoagulation and for her atrial flutter, and there was increased risk of bleeding. So we wanted to give her, we were giving her first line immunosuppression with steroids, and we gave her ATT for a period of 2 months before initiating her on DMARDs, ma'am.
Okay, so I think it's very unclear about this case as to what is actually happened, and RF can be positive in a percentage of the general population. Just having that value, it's difficult to say that this is because of rheumatoid arthritis. Anybody wants to?
Sorry, sir. It was 76, sir. No, sir, it doesn't. Hmm. Sure. Sorry. Sorry. No, ma'am, she didn't. She didn't have any joint involvement. Sure, I'll mention it. Mm. Mm. Mm.
Okay, we will move on to the next presentation. Dr. Nishant, feathery footprint.